So here's a kind of drill, maybe another step into this is so what suggestions do you have to help providers that are in the trenches, in the care delivery system, they're trying to meet goals of population health. And their goal is to, for it to be focused on individuals and outcomes. So what kind of advice do you have for the system? Sharon, you want to start us again?
Sure. I mean, I think that it's an opportunity for provider organizations to get multidisciplinary groups together and start to think about how their own policies or clinical protocols are based on population health and knowledge, as opposed to based on their own clinical workflows, or this person happens to have an interest in this, so we're all going to ask this question. And I think it's a good exercise to start. As you were talking earlier about one of the goals of this, which is how do you marry the population health with the individual outcomes? I mean, take a clinical practice where they want to create a population health based but individualized protocol for people with diabetes, right? So, you get the group together and you say, okay, within a year, everyone should have had a podiatry check, an ophthalmology check, and an A1C draw, blood draw. So that's your standard. Then it's individualized by saying this person had a lot of issues during their last podiatry check, so maybe they need 2 this year. Or this person's A1C is not where we want it to be, so now we have to do something individualized to get their A1C to a specific range. So you take your population health metrics and you apply them and then individualize them. And I think that allows you to be outcomes focused while still staying true to your population health standards.
Yeah, good point. Very good point. Richard?
Yeah, and I think, just a word about, I think we're seeing a lot of provider organizations that are still in the process of investing in the types of information systems to be able to collect the right kind of data, patient-reported outcomes, start gathering data around social determinants that Sharon had mentioned, and to piggyback on, as well as the clinical outcomes, but to piggyback on Sharon's point, I think the first step is just coming together and bringing folks together and start figuring out ways, even if it's manual, on how to solve the problems of population health, especially when we're talking about complex populations. Here in California, we're really struggling with developing integrated care models. Just bringing primary care folks together with behavioral health care folks, if you can tie it together with some type of a shared analytics system or IS system, that's great. But even if you can't, just start the beginning processes of case managers talking to each other, trying to coordinate primary care with behavioral health care, for example, and then link that to addressing the social determinants. The social determinants, I think, are going to come up a lot today because it really is a differentiator in terms of long-term successful outcomes for particularly complex populations in communities that have chronic mental health or primary care conditions.
There's no question. And obviously the cost factor of dealing with those chronic conditions as well, comorbidity, et cetera. So the third one I know you both have a lot of experience with is really around the idea of to what degree has care management and clinical communications, electronic interoperability kind of played a role or should play a role in supporting successful or what success looks like for population health management?
Start off again. So, unfortunately, as people started implementing electronic health records, the focus has been much more on interoperability and much more on meeting the National Health Standards Group, being compliant with that, than it has been on actual support of the clinical workflow. So I think that what's happening now is that clinicians are using it because they're using it. And billing departments have been relying on having an electronic record. But the work that needs to be done is the work of how do you make this clinically valuable? So think about the example I gave earlier for diabetes. if you think about that, a well-organized clinical record is absolutely the key. So it's not just pushing the results of appointments or tests to the clinical record. It's alerting the clinician that there have been events or that there are results in the record that need attention. So then you get into the kind of, it's not enough that my A1C was, very high. It's that it was high enough that the computing program behind the clinical workflow is able to say, wow, this one needs to be escalated fast. And this
Right.
one low enough that it doesn't have to be escalated fast. And so, interoperability is one piece of it, but what we really need to be doing is getting the clinicians to say, how do we use these systems in such a way that they're supporting efficient care delivery and making sure we're not missing anything.
Great point.
Sure that the industry has moved in that direction yet.
To what, I mean, I'm curious, Sharon, just the follow-up question. I'm curious to hear you say, to what degree is it important that the process within the clinical setting changes to even allow some of this outreach? In some situations, there is no even attempt to communicate some of these key aspects.
Right, exactly. And I think, again, it's because, and I say this as someone who has done clinical work in a psychiatric setting and then also has done a lot of IT stuff. You pay attention to the loudest voices. So the people who usually run the implementations are IT people and billing people, because that's been the biggest focus.
Right.
And what I think we haven't really done is individually sit down with clinical groups. And I do think that, we talked a little bit earlier about getting your groups together. You have to get the multidisciplinary group together, because it's not just the physician, it's not just the nurse, it's not just the PAs, it's not just the CRNPs, it is the social workers, it is the home health people. And so, getting a broader view of that and saying, how do we use these tools that we have? And as Richard said, some of them, you're going to just pick up the phone because there aren't the electronic tools to do that. So, we're in a very strange place where lots and lots and lots of people have electronic clinical records, and much of the information is simply not usable.
Right. Good point. Richard?
Yeah. But I think I think we have seen some success though, when you see an effective, pairing of care management, clinical communication, and the use of electronics, platforms, particularly in the area of targeting certain populations. And I know an example of that here in California, if you just a couple of years ago, with a large health plan and provider targeting an SMI adult population with high recidivism rates for hospital readmission, tying the case management that was actually field-based with laptops in the field that can communicate clinical information directly to the payer care manager, and with daily or weekly updates, progress notes, care plans, those types of things, all communicated from the field-based care manager in this example, and getting it through interoperable, systems to be, evaluated by the treatment team so they can make treatment decisions, length of stay decisions, those types of things. When we've seen that, it's worked very well, but it really has been in pockets, and I don't think we see it in large systems yet, or at least I haven't.
Yeah, very good point. And again, I think to your point, the interoperability kind of is the key attribute. And I think the challenge is obviously the data set for mental health care is obviously very non-standardized and doesn't really match up easily to the physical health setting. But again, there's lots of work to be done, but certainly it's an important aspect. So my next question really is, so what key processes would you recommend that a provider organization could take action on or should take action on in preparation for this kind of industry-wide focus on population health? And Sharon, I know you've got plenty of exposure to this, so go ahead and start us off.
So you have to be ready for what's going to come, right? You have to say, you know, the healthcare system is not really working very well. So at some point, the federal government, CMS, the payers are going to be asking for a real focus on population health. But you also have to not paralyze yourself with creating so many steps and with creating such a complex flow chart that nobody's ever going to be able to follow it.
Right.
So my suggestion is to create the multidisciplinary group that we were just talking about earlier for at least one specific disease state that your organization treats a lot of, right? So you have the group document a flow of all the best practices for the disease, and then you discuss how would it be provided and how would it be reimbursed. So these are not just services that you do. These are services that take the whole population into account. Then you use that blueprint for your defined population health protocol. So as an example, you work in a geriatrician environment, you work with geriatric population, and you're designing a protocol for congestive heart failure. And you know that daily weighing is important for patients to, you know, so that you can determine when they're beginning to retain fluids. But you're not going to get reimbursed for going out and checking people's weights, and you're not going to get reimbursed for, you know, even telephonic like daily calls for weight. So in your protocol where you say that's a really important thing, you then assign someone on your multidisciplinary team, perhaps a social worker, to figure out what services are available in our area agency on aging and how do people get access to those, and how many folks in our practice who are in this group already have some kind of supported you know, external aging help, like who's eligible for in-home services. And
Right.
then you can contact, or that person can contact those external groups and begin to think about how you add that to your population health, but you're not getting paid to do it. The costs for having someone on your staff help coordinate access to those services, however, get offset by whatever benefits you're going to get from being able to show the health plan that you're doing a good job, so you get your performance bonus. So it's like thinking systemically, but not making yourself so crazy that you then go, oh my God, this is too big and I just can't do anything. So start with one thing, one protocol, one disease group, one geographic population, and then branch out from there.